Good morning, Chairman. We are ready to begin.
Good morning, DeLauren. If you will conduct the roll call of board members, please.
Yes, Chairman. I will begin with Roger Folsom,
Here.
Tommy Hopkins,
Here.
Kathleen Ruth,
Here.
Norman Boyd,
Here.
Robert Coles, Just for the record, Chairman Robert Coles is here. David Cruz,
Here.
Shane Mobley,
Here.
Cynthia Rucker, Anthony Williamson.
Here.
Chairman, that completes my roll call.
Thank you, DeLauren. So we certainly have a quorum and we call the meeting to order. Good morning, everyone. Previously sent to you were the minutes from July the 9th. Last Board Secretary, Dr. Kathleen Ruth, has she's had an opportunity to review those minutes? And if so, would she move for approval?
Yes, Mr. Chairman, I move for approval of the July minutes.
I have a motion to move for approval of the minutes. Is there a second?
Shane Mobley seconds.
Shane Mobley has seconded the motion. So all those in favor signify by aye.
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 Any opposed, no. Minutes are approved. We have several items to consider today for final adoption, and we'll have several presentations also in the agenda this morning. Earlier this morning, the Care Management Committee met, and Chairman of that committee, Anthony Williamson. We will ask now for a report from that meeting. Good morning, Anthony.
Good morning, and thank you, Chairman Folsom. We did meet earlier this morning, and we had a couple of presentations to hear. The first one was from Maxine Elliott, our Deputy Executive Director, regarding Georgia Horizons, which is our new case management online platform for the Elderly and Disabled Waiver Program, or EDWP. It's a new application that went live on May 18th with the aim of modernizing the application process and decreasing administrative burden, increasing efficiency and regulatory compliance, as well as achieving faster turnaround times on applications. And we heard a lot of great news about the new system. The transition that occurred in May was successful, and Maxine reported that we are already seeing numerous benefits from having Georgia Horizons in place, including one of those being increased program integrity. And then we saw a kind of a brief demonstration of the system and thanked her for the report. It was very informational. And then our next report was from Emily Hatchett regarding Great Health and our rural health transformation, just a status update on that. We learned that grants are definitely proceeding. 216 million of the 218 that was allocated has been obligated. The team is beginning to prepare for year 2, which is coming soon. A lot of work has been focused on the AHEAD program, which is the value-based care initiative that is included with Great Health. Pleased to report that 87 of the 93 hospitals in rural counties have signed letters of intent at this time. Emily reported that the first wave of work also included 3 different assessments with those facilities, looking at 1, technology, 2, the stability of those hospitals, and then 3, kind of overall operational readiness. Each hospital received a grant of $750,000 to begin preparing for ahead as they see fit at their discretion. And she mentioned there were 28 other projects for residents of rural Georgia that are taking place outside of the work with the hospitals. The advisory committee that was mentioned earlier in previous reports has been selected. That group will hold their first meeting at the end of August. And her team is still gathering a lot of stakeholder input. We had some questions around value-based care and, you know, what that has meant historically in our world, and how we want to ensure that it doesn't penalize our providers. That was the end of that presentation. So a great update by Emily, and we called the meeting to close. Thank you.
Thank you, Chairman Williamson, for that report. Any board members have questions for Anthony? Hearing none, we'll move on. Again, thank you. We'll move now to Commissioner Burke's report. Good morning, Commissioner.
Morning, Mr. Chairman and members of the board. I want to always recognize the time that you guys give us to give us advice and support as we continue our mission here at DCH, which is always challenging, never boring. So again, want to thank y'all for your service to the state. You know, it's August, and being from South Georgia, I've grown up and kind of used to the heat, but we're always looking forward to the changing weather and football season. So, you know, we're always looking for that first hint of fall after the rough summers that we have. So I hope y'all are hanging in there and having some time with your families. As Anthony just mentioned, we did update the Care Management Committee on rural health, and we are excited about the fact that we've obligated the majority of our award, and we're working on the budget for next year. It's hard for me to describe the amount of work that's gone into this program, which is a brand new program that was, bestowed upon us by Congress last year. And we're happy to see it. It's a transformational endeavor, but you know, the team members that are implementing that already have full-time jobs. So this is just an added workload to them, and I know they've been working really, really hard, long hours, building up some new team members to assist with the implementation. Everybody's impatient and they want dollars flowing, but CMS has required us to build in a significant amount of infrastructure to be sure the program funds are spent in a proper way, and it's in a reimbursement fashion. So we will be getting invoices from the awardees for monies that they've obligated, and we'll be paying them back. So that just takes time. So, but I think talking to our CMS partners, Georgia seems to be ahead of most states in the infrastructure, because we already had a good grant program in our Office of Rural Health that I'll talk about a little more in a minute, have been in this space of trying to help rural healthcare in Georgia for many years. So we hit the ground running. So again, just want to remind our team how privileged I am to work with them, and the amount of hard work that they've done to successfully implement this very, very challenging program in such a short period of time. We'll talk further about HR 1 today with some of the agenda items, so I'm not going to spend any time on that, but Stuart will be giving us an update on that with some of our proposals. The House and Senate are kicking off their summer fall study committee, and there's several of those that we'll be participating in and reporting on. And again, just our way of looking for partners to help solve these challenging problems that we have. And we look forward to any action items that we're, I'm not sure if awarded or rewarded, voluntold. There'll be all kinds of action items that will come out of those study committees, and we'll look forward to working with the House and Senate and the governor's office on that. Another issue that we've been working hard on is called provider revalidation, and this is where we update the Medicaid providers in the state to make sure we know who they are, where they are, and that there are no issues with their eligibility to be Medicaid providers. We have done a lot of work in the last couple of years to automate that process. So there are a lot of providers that don't have to do anything because we've automated it, but there are still some, several thousands that have not. And the CMS and our federal partners, this is a very, very high level focused area because of the concerns about fraud, waste, and abuse. And want to make sure that the providers that are billing the state of Georgia and the federal government for services are actually doing what they're supposed to do and located where they say they are. And so this is an extremely important issue. We'll still get some folks saying that we have kicked them off the rolls inadvertently, and we have done everything we can to make sure people know that they've got to go through this process and let them know how to do it. So we'll continue to work through that, but you guys may continue to hear from folks that have gotten those notices from us. Another exciting thing was National Healthcare Surveyor Week, and we have 133 surveyors in our Healthcare Facility Regulation Division. They've done 9,450 surveys across the state this past year. Anthony Moss is our director there. They do great work, very challenging conditions, and I want to recognize those people for the service to the state. SHBP has open enrollment coming soon, and they've been working on several things. We'll be hearing from Louis Amos about some of those issues in a few minutes, so I won't spend any time on that. And as I mentioned earlier about the State Office of Rural Health and the work they're doing for the Rural Health Transformation Program, they got new digs lately. We had a ribbon cutting down there. I appreciate the chairman being present for that. We had a lot of people from the department attend, as well as local folks and a lot of hospital and other healthcare providers that came. It was a great day, and the staff there were excited to show off their new office, which was a long time coming, and I'm really excited about them being able to work in just a better conditions to do the hard work that they have. So we're excited about that. Mr. Chairman, that's all I have. I'll be glad to move on to employee milestones, but I'll certainly stand for questions.
Any questions from board members for the commissioner? Okay, proceed on, Commissioner.
All right, starting with 20 years of service, Shajuana Latoya Wright at Office of Government Relations, Donna Martin at 15 years, Office of General Counsel, Keisha Payne Holloway, 15 years, Malcolm Wells, 10 years at Office of General Counsel, Kamal Dixon and HFRD at 10 years, Gladys Paul, 10 years at HFRD, Donna Lee, 10 years at HFRD, Philip Anthony Ramsamy, 5 years, HFRD, Jesse Michael Cox, Office of Health Planning at 5 years, Daisha Black, HFRD at 5 years, and Courtney Mack at HFRD for 5 years. We have numerous one-year awardees, Dana Jackson, General at the Georgia Composite Board, Megan Mason at the Composite Board, Lanika Dancy, Division of Financial Management, Jaslyn Gaines, Office of Human Resources, Pamela Potempa Rivers in Medical Assistance Plans, Brittany Harris, Medical Assistant Plans, Amani Guerrera, HFRD, Cora Bullock, HFRD, Amber Franklin, HFRD, and Kayla Gale in the HFRD. I want to thank all those employees for their service to the state and wish them continued success here with our agency. Thank you, Mr. Chairman. That concludes my remark.
Thank you, Commissioner. We certainly echo those employee congratulations to all those employees celebrating milestones, and we appreciate your work and dedication to the state of Georgia. It was a pleasure to be with the team at the Office of Rural Health ribbon cutting, and I certainly want to congratulate them. Thank you for the invitation, and appreciate all the work that will come out of that new facility for healthcare in rural Georgia. So again, thank you. We'll move on into our working items. First one is rules and regulations for end-stage renal disease facilities. And Patrick Long, Associate General Counsel, will present this to us this morning. Good morning, Patrick.
Good morning, Chairman. Good morning, Commissioner Burke and members of the board. Today, the Division of Healthcare Facility Regulation presents rules for final adoption for end-stage renal disease facilities, or ESRD. These rules are found in Chapter 111-8-22 of the Department's Rules and Regulations. These rule revisions update the requirements for health screenings for ESRD employees, including screening for tuberculosis. The revised tuberculosis language aligns with the recommendations for the Centers for Disease Control and Prevention. A public comment hearing was held via Zoom on July 14th, 2026, and written comments were accepted on or before July 16th, 2026. There were no written or verbal comments received by the department. At this time, we would respectfully request consideration today for final adoption of these rule changes, and I'm happy to answer any questions.
Any questions for Patrick from board members? Hearing none, is there a motion for approval for final adoption?
So move, Dr. Coles.
Dr. Coles has made a motion for approval. Is there a second?
Second, Hopkins.
Dr. Hopkins has seconded. Any further discussion? Hearing none, all those in favor of the motion signify by aye.
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 Opposed, no. Anyone abstaining? Motion passes. Thank you, Patrick, for that presentation.
Thank you. Have a wonderful day.
Our next item is medical assistance plan, state plan amendment. It's the Medicaid community engagement requirements for certain adults. And Stuart Portman will present this to us this morning. Good morning, Stuart.
Good morning, Chairman, and thank you, Commissioner Burke and members of the board. I'm Stuart Portman, the Medicaid Director within the Medical Assistance Plans Division here at DCH, and this is the summary of public comments from the initial adoption public notice on July 9th, that board meeting, as you may recall, which was a bit lengthy, and I'll just give you some forewarning that we did receive a number of comments, and this is also a little bit lengthy. So I am presenting the summary of those public comments to align coverage for eligible adult populations currently covered by the state's Pathways to Coverage 1115 demonstration waiver program with federal statute and CMS regulations and guidance. The department seeks your favorable consideration for final adoption pending CMS approval. As a reminder, Section 1902XX of the Working Families Tax Cut Act establishes a minimum 80 hours per month community engagement requirement for applicable individuals, ages 19 to 64, applying for or enrolled in Medicaid. This new requirement is intended to empower Medicaid beneficiaries through employment, education, or volunteer service, thereby helping the individual to achieve self-sufficiency and independence. Applicable individuals must meet the community engagement requirements at application, renewal, and during various periods of enrollment. DCH has implemented procedures to ensure these requirements are verified using reliable information available to the state and will revise its processes to incorporate all exceptions identified herein. The current Pathways waiver will be amended no later than January 2027 to comply with the new WFTC provisions. In practice, this means the Pathways to Coverage 1115 demonstration waiver will be renewed to only allow Georgia to apply the community engagement requirement to those under 100% of the federal poverty level. The WFTC defines the applicable individuals that must meet the minimum 80-hour monthly community engagement requirement. applicable individuals are required to demonstrate as a condition of their Medicaid eligibility a minimum of 80 hours per month of community engagement activities for 1 month preceding their Medicaid application and during their Medicaid enrollment. Individuals may combine the community engagement activities to meet the 80-hour per month requirement. In order to comply with federal law and regulation, as a reminder, Georgia is mandated to cover individuals under 100% of the federal poverty level, meeting the definition of a mandatory exception or exclusion from the WFTC. And again, this is a population we do not cover today. Full details on this population can be found on the July 9th, 2026 public notice, and the recording of the board meeting is on the DCH website. An opportunity for public comment was held on July 14th, 2026 at 11:30 a.m. via Zoom, and written comments were due on or before July 21st, 2026. The department did not receive any oral comments, but received written comments from the following stakeholders: the American Heart Association, Georgians for a Healthy Future, the Metropolitan Atlanta HIV Health Services Planning Council, the Cystic Fibrosis Foundation, the Equality Foundation of Georgia, the National Organization for Rare Diseases, the Georgia Hospital Association, Grady Health System, DaVita Inc., and the American Lung Association. The comments are summarized as follows. Commenters requested revisions to attachments A and B to include the following diagnoses, codes, and conditions related to medical frailty. One commenter recommended that DCH include all asthma diagnosis codes, including mild or moderate persistent asthma. The commenter indicated that individuals with asthma who experience significant disease burden may lose coverage. Disruption in access to care may lead to preventable emergency room visits, hospitalizations, and poorer health outcomes. One commenter recommended that DCH include codes related to nicotine dependence and tobacco use disorder. The commenter requested that DCH interpret the exemption for individuals with a substance use disorder broadly to include tobacco use disorder. Further, the commenter indicated that ICD-11 specifically includes disorders due to use of nicotine within the substance use disorder framework. Thus, tobacco use is classified as an SUD. Commenters recommended that DCH designate human immunodeficiency virus, HIV, as a medically frail condition on the attachment A list of medical conditions, exempting individuals from the Medicaid community engagement requirements, and that the designation be implemented through ICD-10 codes. Specifically B20, HIV disease, Z21, asymptomatic HIV infection status, and O98.7, HIV complicating pregnancy, childbirth, and the puerperium. Additionally, the commenters requested that DCH identify individuals with the HIV designations on an ex parte basis using claims, encounter, and pharmacy data available to DCH. Additional commenters requested that DCH accept evidence of a filled antiretroviral prescription as an independent alternative identifier. Commenters requested that acquired immunodeficiency syndrome, or AIDS, be included in the attachment A in addition to HIV. Commenters requested that DCH move sickle cell disease to attachment A instead of including it on attachment B, as sickle cell is a complex and disabling condition that significantly impairs an individual's abilities to sustain 80 hours per month of community engagement activities. Commenters indicated that sickle cell disease impacts an individual's ability to complete community engagement activities, not only during acute crisis, but also during periods of chronic pain, fatigue, and organ complications. This request was limited to D57 codes and does not extend to individuals who possess the sickle cell trait. Commenters recommended that DCH designate the following conditions as medically frail conditions on Schedule A. Commenters stated that including the below conditions will ensure that all patients suffering from various stages of end-stage renal disease are captured as part of the intended population of medically frail individuals. Those include CKD stage 4, severe, CKD stage 5, ESRD, dependence on renal dialysis, encounters for dialysis care, kidney transplant status, transplant failure, transplant infection, other complications of kidney transplants, unspecified complications of kidney transplants, waiting organ transplant status, and kidney transplant aftercare. Commenters recommended that substance use disorder base codes be included in attachment A and or attachment B. Commenters noted that attachment A includes SUD that has resulted in persisting dementia or memory impairment, and that attachment B did contain some SUD codes, but only when accompanied by an acute crisis, such as intoxication, withdrawal, delirium, psychosis, or induced mood or anxiety disorders. Commenters also urged the department to adopt a broad and flexible approach to medical frailty and special needs exceptions. One commenter recommended that DCH utilize the National Organization for Rare Diseases, or NORD's database, as a reference for identifying medically frail members. Commenters recommended that DCH should establish a transparent process for periodically reviewing and updating qualifying medical conditions and diagnostic codes. Stakeholders should have meaningful opportunities to recommend additions or revisions, and beneficiaries should receive adequate notice before any changes take effect. The department thanks the commenters for their written comments and support. Relating to requests for revisions to attachments A or B for medical frailty, as a reminder, federal regulations define medically frail individuals as an individual whose physical, mental, or other behavioral health condition significantly impairs the individual's ability to comply with the community engagement requirements. Again, as a reminder, a medically frail individual is someone who is blind or disabled, as defined by Section 1614 of the Social Security Act. Someone with a substance use disorder, excluding an individual in stable recovery, which means someone who is in recovery for 5 or more years. Someone with a disabling mental disorder, someone with a physical, intellectual, or developmental disability that significantly impairs their ability to perform 1 or more activities of daily living, or someone with a serious or complex medical condition, which is a medical condition that is life-threatening, seriously disabling without necessarily being life-threatening, causing significant pain or discomfort that can cause serious interruptions to life events, requiring a major time or effort commitment from caregivers for substantial periods of time, requiring frequent monitoring, associated with severe consequences or negative consequences for someone else, affecting multiple organ systems, requiring management to tight physiological parameters, requiring coordination of multiple specialties, requiring treatment that carries a risk of serious complications, or requiring adjustment in non-medical environments. Additionally, federal regulations require the state Medicaid agency to develop a list of diseases, diagnoses, disorders, and other health conditions to identify individuals who meet the criteria for medical frailty. The list must be auditable, justifiable, and consistent with the definitions above. Further, the list must be revised on a regular basis to add or remove diseases, diagnoses, disorders, or health conditions based on the state's experience applying the medical frailty exclusion. DCH will develop a process for individuals with disease, diagnosis, disorder, or health conditions not on the list to request consideration for the exclusion. Per federal guidance, the classification of medically frail is not based solely on diagnosis. To do so would result in the inclusion of individuals whose conditions do not significantly impair their functional capacity, meaning that they are able to perform 80 hours per month of community engagement activities. States must consider the severity of an individual's condition as relevant to whether that individual is capable of meeting the community engagement requirements. In response to public comment, DCH will add HIV codes B21, HIV disease resulting in malignant neoplasms, to attachment A. Codes Z21, asymptomatic HIV infection status, B20, HIV disease, and B97, HIV type 2, will be added to attachment B. Code 098.7, related to HIV complicating pregnancy, childbirth, and the puerperium, will not be added to attachment A or attachment B. Individuals that are pregnant receive services through pregnancy Medicaid. Thus, adding HIV complicating pregnancy, code 098.7, to the list is not required. DCH will review the remaining diagnosis codes listed and will add them if deemed appropriate and in accordance with federal law. It is also important to note that HIV and AIDS are identified with the same ICD code, and therefore both diagnoses are included in attachment A. DCH will develop a process to allow stakeholders to recommend revisions to the list of conditions in attachment A and B. Notice outlining that process, including opportunities to provide feedback, will be posted publicly. Additionally, the following comments were received regarding the process of determining medical frailty. Commenters requested that DCH publish the policies and procedures it intends to utilize for reviewing and administering the medically frail exclusion. Specifically, commenters recommended that DCH publish information on how the state will determine whether a condition affects an individual's ability to work, what documentation is required, who will make the determination, and the approval and denial process. Commenters recommended that DCH accept self-attestation of medical frailty through December 31st, 2027, and commenters requested additional information on the renewal requirements, evidentiary standards, and the treatment of conditions that fluctuate over time. Related to the review and determination of medical frailty, DCH will publish its policies and procedures for reviewing and determining medical frailty. DCH, however, will not allow self-attestation. Commenters submitted the following recommendations related to tobacco cessation programs and nicotine dependence. One commenter requested that DCH should use application and renewal processes as opportunities to screen individuals for nicotine dependence and offer tobacco cessation programs available through Medicaid and other state programs. Commenters also recommended that enrollment in tobacco cessation programs be recognized as participation in a drug and alcohol treatment program. The department thanks commenters for those comments. Newly enrolled members receiving services through a care management organization are asked to complete a health risk screening at the start of their enrollment. The health risk screening is a screening tool that helps individuals identify and understand their health risks and monitor health status over time. A screening includes a questionnaire, an assessment of health status, a personalized feedback about actions that can be taken to reduce risks, maintain health, and prevent disease. Additionally, members enrolled with the CMO are offered medical screenings as part of their benefit package. Fee-for-service applicants and members can receive screenings through their physicians. The Georgia Medicaid program covers medically necessary tobacco cessation services for pregnant and non-pregnant members. Tobacco cessation services include counseling, pharmacotherapy medication, and a telephone tobacco quit line. 2 12-week tobacco cessation treatment periods are allowed per member per year. Enrollment in the tobacco cessation program does not qualify as a drug and alcohol treatment program. Tobacco use disorder on its own is not a qualifying diagnosis for drug and alcohol treatment programs, but it may qualify with a diagnosis of substance use disorder. The following comments were given regarding the short-term hardship exemptions included in the community engagement regulations. Commenters commended DCH for allowing short-term hardship exemptions. However, commenters requested that upon implementing the short-term hardship exceptions, DCH apply the disaster and high employment exceptions automatically, confirm approval with CMS, and update the qualifying county list online regularly. Commenters recommended that DCH define the travel circumstances as broadly as possible to cover those needing to travel, minimizing documentation requirements, and providing a clear explanation of the exception and instructions, and developing a process to transition individuals with ongoing medical hardship into longer-term exceptions when appropriate. The department thanks commenters for their written comments and support. DCH will comply with the federal regulations and will automatically apply the short-term hardship event in cases involving an emergency or disaster that has been declared by the President under the National Emergencies Act or the Robert T. Stafford Disaster and Emergency Assistance Act. Confirm approval with CMS and update the list of impacted counties. DCH will define the policy and post requirements needed to meet the short-term hardship events. The following comments were received regarding public reporting. Commenters requested that DCH make publicly available, including online, timely and detailed monthly reports of outcomes related to work reporting requirement applications, renewals, and terminations, as well as metrics related to consumer assistance like application processing and call center wait times. Commenters requested that DCH develop comprehensive reporting requirements and metrics that include enrollment and application numbers, application processing times, renewal rates, compliance reporting details, termination numbers, reinstatement data, exclusions by category, disenrollments by reason, and demographic information. Additionally, commenters requested that this data be made publicly available online, updated at least monthly, disaggregated by race and county. DCH thanks the commenters for their comments. The department will publish publicly available reports on its website and determine the specific metrics to be included within the reports. The following comments were received regarding the verification of community engagement requirements. Commenters thanked DCH for allowing applicants and enrolled members to demonstrate proof of compliance 1 month preceding their Medicaid application and 1 month during the redetermination period. Commenters requested that DCH remove the phrase during various periods of enrollment as the language is vague and could lead to confusion for beneficiaries. Commenters requested that DCH plainly state that compliance verification will only take place at the time of application and renewal. DCH thanks the commenters for their comments. DCH will verify compliance with the community engagement requirements 1 month preceding the submission of a Medicaid application, 1 month during the redetermination period, and during a change in circumstance. DCH maintains the right to conduct audits as necessary. The following comments were provided regarding member protections and due process rights. Commenters requested that DCH include the provisions outlined in 42 CFR 435.558 in its state plan amendment prior to submission to CMS. This includes continued coverage pending determination, the receipt-based clock, the screening for other coverage, fair hearing rights, and MAGI reconsideration. Commenters also requested that notices of noncompliance be issued in plain language, identify specific data sources relied upon, allow the right to submit correcting information, and allow for self-attestation where appropriate. Commenters requested that applicants are not required to disclose HIV status to an eligibility worker or as part of a Medicaid application process. The department thanks the commenters for their comments and will ensure that its state plan amendment meets the required federal standards. Additionally, DCH will ensure that all written communications will comply with federal regulations. Applicants will not be required to disclose their HIV status. The following comments were made regarding the department's outreach plan. Commenters requested that DCH publish its proposed outreach plan, notice templates, and language access approach, and that DCH work with the Georgia Gateway community partners to assist with community-based outreach efforts. Commenters urged DCH to invest in robust outreach and consumer assistance, including clear notices, timely reminders, multiple communication channels, and accessible application assistance. Commenters noted that DCH must take steps to minimize unnecessary coverage losses that disrupt patients' access to care and increase administrative costs for the state. Commenters requested that DCH describe the medically frail exemption comprehensively and in plain language in application materials, renewal forms, and outreach communications. Commenters further noted that all public-facing materials related to community engagement requirements be written in plain language and be multilingual. The department thanks the commenters for their comments and will ensure that all written communications comply with federal regulations. DCH will publish its outreach plan and will work with external stakeholders and community-based organizations to enhance our community-based outreach efforts. The following comments were made regarding fiscal transparency. Commenters recommended that DCH provide a public breakdown of the fiscal impact for state fiscal year 2027 to disclose administrative costs, benefit costs, and the estimated number of members subject to the community engagement requirements. The fiscal impact identified for state fiscal year 2027 represents estimated projections due to various complexities. Additional estimated projections will be shared as DCH gains actual experience with the new population. The following comments were received regarding use of ex parte verification and reduced administrative burden. Commenters recommended that DCH maximize ex parte verification as much as possible to streamline the verification process. Automated and ex parte processes can improve accuracy and lower administrative burdens on members and their healthcare providers. Commenters noted that DCH should take steps to protect patients' access to care by reducing unnecessary administrative burdens, maximizing access to exemptions for eligible individuals, and strengthening enrollment and renewal processes. Commenters recommended that DCH use multiple identification pathways to determine medically frail individuals and not rely solely or primarily on diagnostic codes to capture both diagnoses and undiagnosed rare diseases. Identification pathways include, but are not limited to, diagnosis code, orphan drug prescription data, specialty procedure codes, specialist claims data, evidence of enrollment and third-party copay assistance or patient assistance programs, and utilization history. DCH thanks the commenters for their written comments and support. DCH will utilize available claims data, electronic data sources, utilization data, and our contracted vendors to the extent possible to automate and streamline the process, thereby reducing administrative burdens on members and providers. The following comments were received regarding engaging Medicaid members and caregivers. Commenters request that DCH leverage existing advisory bodies such as the Medicaid Beneficiary Advisory Council, Georgia's Rare Disease Advisory Council, and disease-specific patient advocacy organizations to obtain recommendations on implementing the community engagement requirements. The department thanks the commenters for the written comments and support. DCH will engage external stakeholders to assist with implementation activities related to community engagement requirements. This brings us to the conclusion of the public comments. Once again, the department thanks the public for robust commentary on this initiative. DCH will continue to share information as it is available. So in conclusion, the department is requesting the board's final adoption of the proposed changes to amend the Medicaid state plan to include provisions mandating certain enrolled Medicaid beneficiaries and certain applicants to comply with the newly established community engagement requirements. And I am happy to answer any questions you may have.
Any questions for Stuart from board members?
Chairman, I don't have a question, but a comment. Thank you, Stuart, for a very thorough report and also for your team for taking these considerations, these recommendations for under consideration and for a comprehensive explanation to the recommenders, so the commenters. So thank you so much for a great job on that.
Thank you.
Any further questions? Hearing none, do we have a motion for final adoption?
Hopkins, so moved.
Dr. Hopkins has moved for final adoption. Is there a second?
Second, Kathleen Ruth.
Kathleen Roof has moved for second. Any further discussion? Hearing none, all those in favor of the motion signify by aye.
Aye.
Opposed, no. Anyone abstaining? Motion carries. Stuart, you can sit down and have a little rest before your next presentation, but thank you for that.
Perfect. Thank you.
Significant amount of geography in that presentation. Our next item is SHBP calendar year 2027 member contribution rates resolution. And of course, Louis Amos, Executive Director of the State Health Benefit Plans, will present to us. Good morning, Louis.
Good morning, Chairman Folsom, Commissioner Dr. Burke, and the members of the board. I'm Louis Amos, the Executive Director for the State Health Benefit Plan, and I will be making a presentation in terms of a recommendation for the 2027 benefit plan year and to bring the committee updates on some activities for this year. Next slide. As you know, our purpose is shaping the future of a healthy Georgia, improving access and ensuring quality to strengthen the communities we serve. The agenda today, I'm going to talk about the accomplishments during the 2025 and 2026 year, talk a little bit about the SHBP membership overview, a plan overview, historical trends, and then recommendations for the 2027 plan year in terms of plan options, plan design, and member premiums, and also talk a little bit about open enrollment. Accomplishments. In 2026 and 2025, we focus on mental health awareness with our medical vendor partners along with the benefit professionals. We did a One Mind, One Body conference in May that focused on grief, stress, trauma, anxiety, and burnout. During the BenPro conference, which is our annual conference for state and the school system benefit professionals, it was a 2-day conference. We focused one of the days on benefit administration, but then the second day we really focused on mental health in terms of dealing with mindfulness, anxiety, depression, 988, and other things as it relates to mental health activities. We partnered with Kaiser to do a Thriving School Summit, and it was focusing on school personnel, mental health, and provide them tools and strategies to basically deal with the day-to-day activities of their lives. We also partnered with Kaiser Theatrical Experience, and they demonstrated in terms, again, how to manage stress and deal with situations of that nature. Go back, babe. Okay, we're having a few technical challenges here. But one of the other things from a clinical perspective, we had 2 pilot programs. As you know, diabetes and hypertension are our 2 most expensive items. We did a pilot program, a diabetes reversal pilot program with Verta Health. We're in the 6th month of that particular pilot. We have over 1,000 active participants, and 25% of them have seen a reduction in their medication. 2% have seen a reduction in their A1Cs, and 5% have seen an average weight loss. So we've done great with that. The next pilot was a hypertensive management, and that was through Hello Heart. And this is primarily for the rural areas in the state. We had over 4,000 participants in 120 rural county areas where they had an opportunity to have a blood pressure cuff, then had access to diagnostic coaching and tracking. Over 133,000 blood pressure readings were taken. 70% of the participants who started with a high blood pressure rate, we saw a reduction in that rate. Next slide. Another program that we're really excited about, we just really started, we implemented what we call a community-based nursing program with nurses, RN, and that's with both Anthem and United. And these are field-based nurses. And then they are able to do educational event, biometric screenings, health education, and then one-on-one counseling. There are 6 nurses. United has 1 that's in the Macon area. And then Anthem has 5 in Savannah, Albany, South Atlanta, Gwinnett, and in the Dublin area. As you know, we completed the PBM IFP invitation proposal and has selected ESI as the vendor. And we're currently working through the implementation of that. And things seem to be going relatively well. Next slide. I think one of our highlights of last year was a program we partnered with ShareCare. ShareCare is our wellness vendor, and they have various challenges throughout the year, but we did one called Jump Shot for Health. And the purpose of this program was to get Title I schools to get active, get out, and get involvement. This was a partnership between SHBP and ShareCare. We had vendor donations from Anthem, United, CVS, the Atlanta Hawks, and Good Sports. And the goal of this particular program, that were going to be 2 full-size regulation basketball courts to the top 2 winners. 31 Title I schools participated. There were approximately over 2,600 participants. The average school had over 325,000 steps, and more than 300 participants had 1 million steps. The 2 winners, and we like to recognize those 2 communities. One was West End Elementary in Rome, Georgia. They were first place. They had over 102 million steps for their team members. And the next was West Harmony Elementary in Monroe, who was second place. So both of those 2 elementary schools received a full-size basketball court. And as you can imagine, it's not only helpful for the elementary schools, but those communities as well. The other schools received from Good Sports equipment was Oakland Elementary, Kemp, Strive Academy, and Anniston Elementary. Membership overview. Next slide. As you can see, the membership basically remains stable, and it's the same pretty much throughout. On the active side, the teachers and librarians are the largest participation, followed by school personnel and then state agencies. I do want to point out it's a little bit different on the retiree side, where obviously the teachers and librarians are still the largest, but then the state retirees are the second, and then followed by school personnel. On the membership, it basically remains fairly the same. On the active side, the largest membership is with Anthem HMO, which has over 238,000 members, followed by Anthem Bronze, 111,000, Anthem Silver, Anthem Gold, Kaiser HMO, United Healthcare HMO, and a high deductible plan. On the retiree side, it's basically split 52% of the retirees in the Medicare Advantage are with the Anthem plan, 48% are with United. Historical trends. The annual cost increase in terms of from year to year, from calendar year 24 to 25, on the medical side, we saw about a 5% increase. On the pharmacy claims, that was a 20% increase. Half of that was due to the coverage of the GLP-1s for weight loss. Cost drivers, as it's been over the years, healthcare inflation, along with significant increases in high cost claims. This year alone, we've had some claims that one particular patient had a $10 million claim. We've had some $8 million claims, and it's not uncommon for us to see $1, $2, and $3 million claims. So we're seeing a significant amount of high cost claims. Continued prevalence, obviously, of chronic conditions, diabetes, hypertension, and obviously cancer is a driving factor in terms of cost. Increased spending on specialty medications and on the anti-obesity medications for the month of June alone, June of 2026, we spent $37.7 million for primarily 2 drugs, Zepbound and Wegovy. As we say, part of what we're seeing, the chronic conditions, you're still starting to see the impact for those members who did not engage during the pandemic. So we're starting to see that. Obviously, as it relates to these these chronic conditions, it's impacted both medical and the pharmacy side. Specialty drugs, you know, that there are new drugs that are coming out. While technology and specialty drugs are becoming available, it's also meaning that we're living longer and costing a little bit higher in terms of the cost. And then the generic drugs, the gene therapy drugs, I'm sorry, is another factor as more of them become available on the marketplace. Next slide. For the 2027 plan year, the medical vendors will remain the same. United Healthcare will offer an HMO, a high deductible, and the Medicare Advantage plan. Anthem Blue Cross Blue Shield will offer the HMO. The HRA plans, that's the gold, silver, and bronze. Medicare Advantage. Kaiser will be the regional HMO. And the pharmacy will change as ESI will be the vendor effective 1/1/27, and ShareCare will remain as the wellness vendor. As we talk about premiums, as you know, we did a look back over the last 10-year period, and the average increase for that period was about 3.3. And when you look at premiums, I know we talk about what times in terms of there were a few years where we had a zero premium increase. But you know, with medical expenses, that runs between 5 anywhere to 10% over that same period of time. So there was an area we had zero premium increases, but expenses remained to continue to increase. Last year, we had a 12% increase in terms of rates. For this year, for the 2027 benefit plan year, the recommendation is to have a 6% member increase for active and pre-65 participants. This is the weighted average. Our subsidies are based on the bronze plan, but with that weighted average, the average premium increase for the self-funded plan is $8.83 per employee and $34.10 for employee and family. To give you a little bit more illustration on the different plans, the bronze plan, it's a $2.04 employee only and $13.38 employee and family. The silver is a $7.06 employee only and $27.43 for employee and family. And the two HMO plans, Anthem and Kaiser, and that's a monthly $12.08 employee only and $41.50 for employee and family. Just a quick note, the gold plan is a $13.48 increase for individuals and a $45.42 for employees. The actual amount will depend on the plan option and tier chosen. There are some increases for the retirees who are that are subject to the years of service process. Next. As we look at the Medicare Advantage, in 2025, we basically changed the funding and went to a level dollar subsidy. The lowest cost plan in the current environment is Anthem, which has a $30 monthly fee, and United with $103. Next slide. For the 2027 benefit plan year, we're not making any benefit plan changes. So remember, we have what's called a Medicare Advantage PPO, which means you have the same benefit in network and out of network. It protects our members from some, as you all know, some of the contractual issues that may come about between the providers and the payers. Minimum premiums for the Anthem standard plan, which is the lowest plan, is going to remain at $30. Members will pay a full cost difference to buy up to other plans of their choice. And basically, members, if they don't make any changes, they're automatically going to go into the same plan that they're currently in for 2026. Next slide. Open enrollment, it begins on October 19th and will end on November 6th. Open enrollment materials will be mailed in September. Participants, while it's a passive open enrollment, we do encourage participants to take full advantage of the 24-hour, 7 days a week flexibility where they can look at plans and make changes. There are two ways to make changes. One, they can do it via website or can do it telephonically. We will be hosting in-house and external meetings throughout the state for both retirees and benefit fairs for the active employees. Next slide. As I indicated, for the retired change period, it's a passive enrollment. So basically, retirees have the option, if they don't do anything, they will automatically be in the same program that they're currently in. Same thing would apply for the pre-65 non-Medicare Advantage folks. Once again, if they don't want to make any changes, they can basically allow it to roll over. Medicare Advantage participants, as we do every year, we really encourage them not to enroll in any kind of supplemental plan, Medicare B-only plan, individual Medicare Advantage plans, because it will result in termination of SHBP coverage. And of course, I mentioned, and I will now pause and respectfully ask the board's approval for the recommendations and entertain any questions might be from board members.
Any questions from board members for Lewis? We are required as a board to approve this resolution or to act on this resolution, so I'd ask for a motion for approval.
Motion
So
for
moved,
approval,
Williamson.
David Cruz.
I heard two. I think David Cruz made a motion and maybe Anthony Williamson seconded. Any further discussion? Hearing none, all those in favor of the motion signify by aye.
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 Any opposed, no. Anyone abstaining? Motion carries. Thank you, Lewis, for that presentation this morning.
All right, and thank the board for your support.
Our next item and final item on the agenda is proposed amendment to Georgia Pathways to Coverage, Section 1115, a demonstration waiver to obtain enhanced federal funding. And Stuart Portman will present this to us. Stuart, if you have any oxygen left, we look forward to this presentation.
Thank you. Thank you. I'd say that was the precursor, but this is shorter. So I can, but good morning again. And thank you. I am also presenting the public notice to obtain enhanced federal funding for the populations to be covered under the new community engagement requirements. This funding request is an amendment to our Section 1115 demonstration waiver renewal that is currently awaiting final CMS action. The department seeks to inform the board of this action, but as this is a financing amendment to our existing waiver, no formal vote of approval is required. Pending approval by the Centers for Medicare and Medicaid Services, the Department of Community Health intends to amend its Georgia Pathways to Coverage Section 1115 demonstration waiver to include an enhanced federal match of 90%. Section 1115A2 of the Social Security Act allows the Secretary of the Department of Health and Human Services to provide federal financial participation for costs associated with an 1115 demonstration waiver. On October 15, 2020, CMS approved Georgia's Pathways to Coverage 1115 demonstration waiver. The Pathways waiver provides Medicaid coverage to individuals ages 19 to 64 with incomes up to 100% of the federal poverty level, who meet up to 80 hours per month of certain qualifying activities and who otherwise would not be eligible for Medicaid. Thus, the Pathways program was an initiative for Georgians to gain access to affordable healthcare coverage. In its initial application to CMS, DCH requested an enhanced federal match of 90%. CMS did not authorize the enhanced federal match at that time. Based upon the mandatory provisions of the new Working Families Tax Cut legislation relating to community engagement and the specific impact and unique impact to the Georgia Medicaid program, DCH is renewing its request to receive an enhanced federal match of 90%. Georgia was granted a waiver of the income level specified in Section 1902A10AI8 of the Social Security Act, which permitted the state to implement at an income level of 95% of the FPL rather than 133% of the FPL for the demonstration group. The demonstration population remains within the statutory new adult framework described in Section 1905Y of the Social Security Act. Accordingly, expenditures for that approved demonstration population should qualify for the full enhanced FMAP allowable under that section, which is 90%. Georgia's initial 1115 waiver was designed and implemented to support hardworking Georgians through a tailored state-specific approach to healthcare coverage. The submitted and approved waiver was unique in its approach because it did not add a work or community engagement requirement to those who were already eligible for Medicaid. Rather, the state created an entirely new eligibility pathway focused on encouraging and incentivizing work and other employment-related activities for low-income Georgians who are not otherwise eligible for Medicaid coverage. Because of this difference, the waiver as originally approved intentionally did not include any exclusions. However, such exclusions and exceptions are now being functionally imposed on the state by federal policy changes under the WFTC legislation. As a result, that shift materially changes the fiscal foundations of the waiver and places Georgia in the position of absorbing new obligations it did not create and did not budget to sustain. These federal changes are effectively broadening Georgia's tailored waiver to cover additional populations not originally anticipated or previously, as we previously discussed in all of the community engagement public notices here today and last month, including those with higher per member per month costs. The state requires additional federal financial support to implement and administer the program in line with the requirements under the WFTC and its associated federal guidance. Georgia does not have the financial capacity to fund this expanded scope without additional federal dollars, and a 90% 10% FMAP funding structure is the most appropriate mechanism to preserve coverage, maintain the program's integrity, and protect the state budget from unsustainable strain. The federal government fundamentally reshaped the operational and financial realities of Georgia's waiver. Therefore, we ask that the federal government also provide the enhanced match necessary to make that expansion viable. To formalize that ask, the accompanying amendment to the Pathways demonstration waiver will be made available for public review along with this public notice, and today marks the start of the required 30-day notice and comment period, after which the state will submit the formal amendment. The community engagement requirements are effective January 1st, 2027. The actuarially projected fiscal impact is as follows, assuming a 90% matching rate. In state fiscal year 2027, the state funds required have an estimated amount of $22,750,000. Federal funds have an estimated amount of $204,750,000. The estimated total for state fiscal year 2027 is $227,500,000. In state fiscal year 2028, the first full state fiscal year of the community engagement requirements, the state funds required have an estimated amount of $120,570,000. Federal funds have an estimated amount of $1,085,130,000. The estimated total for state fiscal year 2028, again, the first full year of the program, would be $1,205,700,000. The combined state and federal total across the first 18 months of this program is $1,433,200,000. With enhanced federal funding, the total state funding for those first 18 months of community engagement would be $143,320,000. Without that enhanced funding, at our traditional state match, the state obligations are estimated to instead total $474,962,480. An opportunity for public comment will be held on August 19th, 2026 at 11 a.m. via Zoom audio. There will be no in-person attendance at the Department of Community Health for that public comment. An opportunity for in-person public comment will be held on August 24th, 2026 at 12:30 p.m. in the DCH boardroom. Individuals wishing to comment in writing on any of the proposed changes should do so on or before September 14th, 2026. Specific details on written submissions can be found in the public notice. Given the magnitude of the impact from compliance with the new required community engagement requirements, the department is moving forward with this formal request for enhanced federal funding. The intent of this public notice today is to initiate that 30-day notice and comment period required for all federal submissions of Section 1115 demonstration waivers and amendments. I am happy to answer any questions you may have.
Any questions for Stuart from board members? Hearing none, thank you, Stuart, for that presentation.
Thank you.
And that serves as public notice, and so there's no further action required today from our board. That concludes our agenda unless anyone has any new business that needs to come before the board today. Well, hearing none, I would remind you that in August, it's customary for us to have two board meetings. And so the next meeting is August 27th. And we look forward to seeing you all at that meeting. And I want to echo the commissioner's comments. I want to thank each of you for your service on this board. We do a lot of work behind the scenes. The staff and the team certainly does a tremendous amount of work keeping us abreast of everything on this agenda. And we make this agenda look fairly easy some days, but there's a lot of work that goes on in the back rooms. And we appreciate all of that. Appreciate each of you. And if there's no further business, we stand adjourned. Have a good day.
Thank you, Mr. Chairman.
Thank you.